All right. So my name is Todd Duellman, or Dr. Duellman. Dr. Smedberg is in the back in the blue shirt here. He's one of my partners at Wisconsin Orthopaedics, and then in the back is the director of kind of our entire clinic and surgery department. That's Jessica Smith. So first off, thank you for coming to the meeting tonight. I don't call it a meeting. We're a small enough group. Feel free to ask questions, shout out, do anything like that. But just to start out, just wanted to give a brief background of, by the way, can everybody hear me okay? Okay. Brief background of Wisconsin River Orthopaedics. It's actually been here since 1968. So our clinic has been in practice since 68, and maybe some of you have had the ability to, or the uniqueness to meet Dr. Wolfgang Dietschy, who was the founder of the clinic. Dr. James Johnson passed away this past year, and Dr. Wilkes joined the clinic in '87. And this tree actually has a lot of meaning. Obviously, they call this the tree of Landry. It's in every orthopedic clinic in the country, basically, and it's modified to your community. What you see is you see a stick holding a tree, trying to straighten the tree, and that's the whole goal of orthopedics. It means to ortho, and ped is ortho is to straighten, ped is a child. To straighten a child is where the name comes from. And so every clinic kind of modifies this tree of Landry to us. We're in obviously pine tree country, so we made it a pine tree with the stick on the side. I was in southern Illinois, it was a corn stalk. So it just depends on where you're at as to how they modify that tree. Currently, we have 5 surgeons operating at the clinic. Myself, Dr. Gallick is the senior partner. I joined in 2006. Dr. Smedberg joined in 14, Walter in 19, and we added a foot and ankle surgeon this past calendar year with Dr. Sorensen. So we're a group of 5, and then we have extenders as well. We also have physical therapy and all those ancillary services, MRI, surgery department, and those types of things. The center was actually built in 2006, and it's undergone 2 expansions or 2 remodels. At this point, we've doubled the size of it. In 2020, we doubled the size of our therapy department. We added a capacity for persons to spend the night. As you remember, 2020 was that COVID time when getting into a hospital wasn't the best of situations. We happened to build an overnight facility at that same time, so persons, when they have surgery, can spend the night if need be, and if they don't need to spend the night, they can go home. So we have that capability. And we doubled the operating room and space and all those things. In this past year, we added more capabilities to our x-ray because obviously we're more physicians, and that was pretty taxing on our x-ray department. So we expanded that as well, and then just did a cleanup of the building. Kind of the rules of thumb is if you're not remodeling or redoing things in 10 to 15 years in healthcare, you're probably falling behind. So we did an extensive remodel this past year. So today's plan is the hip. Basically, like every talk in orthopedics, it starts with just anatomy, and then how do you get your hip problem addressed, or how do you get it looked at. We'll talk about some diagnoses for the hip, and then obviously plenty of time for questions at the end. So hip anatomy 101. This is basically the hip. This is your pelvis here, and then the ball and the socket. The hip is actually just an extension of your femur, your thigh bone. People always say, well, they broke my hip. Well, that's just the top half of your femur. So the top half of the thigh bone is the hip itself, and that's the ball and the socket. Around that hip are the muscles. We're not going to talk a lot about the muscles of the hip today, except for how they pertain to the operation itself and what we do with them during the time of that operation. Just another picture of the muscles, and something that we'll talk quite a bit about is this trochanteric bursa here on the side of the hip. Many people will complain of pain on the outside of their hips, and that seems to be the source. So like anything in medicine, the first biggest thing to do is obtain a correct diagnosis, right? You can't fight your enemy unless you know who it is. So you basically just set up an appointment, discuss with your provider. Most of the diagnosis actually comes from just a conversation. They have a physical exam, x-rays. Often the MRI and CT scan are not required, so people think the MRI or a CT is a necessary thing to get. I would say 95+% of the time we don't actually get those high-end imaging, and we can do most things with x-rays, a physical exam, and a conversation. So it's really not necessary to spend that much money on an MRI. So what's a hip joint? How do you know if it's the hip joint? Where does the hip hurt? First and foremost, pain in the groin. So pain in the front and in the groin is by far the #1 symptom. People will say they have difficulty getting the leg in and out of the car, groin pain, trouble putting on socks. So you're trying to put on socks, you lose your flexibility or mobility, and you have more groin pain. So it's typically invariably where it is. It can hurt, front to back, but if it's not in the groin or front to back, it's probably not your hip. This is not your hip. Pain in the butt is not your hip, and pain that goes down your leg past your knee is probably not your hip. It very well could be sciatica, it could be arthritis of the low back, arthritis of the SI joint, or different spots, but it's clearly not the hip if it hurts in the back where those people are pointing, or in the side, in the flank. That's not the hip. The hip is truly groin. So we're going to talk about 3 major diagnoses today. The first one is called the labral tear, and what that is. We'll talk about hip bursitis, and then we'll talk about hip arthritis and how they all basically present and what you can do about those things. And by the way, I just yell if you got questions. So this is an MRI of a hip. Like I said, we don't use them very often in specialty cases. This is looking at the hip from the top down, but if you look at the labral tear, this little piece of rubber, it almost feels like ear cartilage, like you grab your ear, it's that kind of rubbery stuff. It deepens the hip socket. But this one's tore off. There's a little bit of white going in there, and that's what a labral tear is on MRI. Really not that important, but here's what it looks like. So it causes groin pain and catching in the joint. So if you look at this labrum is just a piece of rubber basically, or cartilage that goes around the socket, and this is showing one that's torn. And once in a while that will flip into the joint itself, causing catching, causing pain, and causing groin pain. It's typically younger patients, runners, people who have been born with something called impingement syndrome, just their anatomy is such that they cause that labrum to tear, and happens in contact sports as well, as you can imagine. So what's the treatment? What's the initial treatment? The initial treatment for all of these things is kind of the common sense answer, right? When you go to the doctor says it hurts when you do this. Well, don't do that. That's the kind of the common sense one. So the first treatment of all of these is activity modifications. And we're all human, so we all do the second one, which is just benign neglect. We just think it's going to go away. Labral tears typically do not just go away. You can try oral medications, the ibuprofens, the Aleve, the Motrins, those types of things. And often they require a steroid injection and physical therapy. I just recently tried to send a patient to Madison for a labral tear, and they had to meet all of these criteria before they would be seen. Just based on most of the time, these things solve the problem before they would be surgical in nature. And so if they check all of those, that you've tried them and exhausted them, then we would entertain surgery. But the vast majority of time, this will take care of it. And what's the surgery for this? The surgery for it is a hip scope, where you actually stick a camera into the joint and you put tools through another hole, so through little poke holes, 4 or 5 little poke holes, well, 3 or 4 little poke holes. And here's the tear, and in this image the tear is sewn back together, just kind of a cartoon version. Sometimes that involves scraping the bone or grinding some of the bone away, but that recovery is pretty long. You can open it up. Most people don't. Most people do it through little poke holes or an arthroscope at this point. Criteria-wise, a lot of times you have to have no arthritis in that joint to do that. If you have arthritis in the joint, that probably is not going to be successful. So criteria-wise, usually it's the younger population that you're trying to salvage the hip joint itself, that you do a scope like that. Next, we'll talk about bursitis. On the sides of our hip, we all have these bony prominences. You can put your hands on your hip and you can feel that bump that sticks out. That's a bone piece. It's part of your hip. But on anywhere we have bone that's close to the skin, elbows, knees, hips, there's a sac, a fluid sac called your bursa that sits outside of it. Basically, it cushions. You've probably heard people that get bursitis of the elbow, they bump their elbow, they get a big sac-looking thing on their elbow. That's just an inflamed bursa. The same can hold true on the hip, and it's truly a pain in the butt, literally. Anyone can have bursitis pain, and it is actually the bane of my existence. I see this more often than not. It can be young patients that are active, it can be sedentary patients, or patients with hip arthritis. So it really is, people will come in and they'll just say, I can't lie on that side, I can't sit in a hard chair, it hurts like heck here, and the pain goes down the sides of their thighs just to about their knee. And so the other people it happens to is patients with low back pain. If you talk to your surgeon colleagues who are spine guys, For gals, they'll say if you have L4-5, a disc at L4-5, you'll get bursitis pain because that nerve actually extends to the sides of the hips. So you do have to decipher that a little bit as to if it's coming from the spine or if it's truly coming from the hip, and that's just a physical exam issue. So what are the symptoms? Once again, we talked about it. The bony bump on your hip, it's painful. Difficulties to sit in a hard chair. People say they can't lay on their favorite side at night. Pain down the thigh. And the important thing is this last one. It does not cause numbness or tingling. If you have numbness and tingling coming from your buttock or the groin and it's going down past your knee and it's tingly, or those probably are signs that you have a pinched nerve or a sciatica type thing. Hip problems do not cause numbness or tingling, whether it be bursa, labrum, or arthritis. They don't cause neurologic symptoms at all. So once again, pain in the trochanteric bursa region is anywhere on the side of the hip where that gentleman is showing it, coming on the outside, going all the way down the thigh. Treatment is almost 99.9% non-surgical, which is no fun for me because I like to do surgery. But anyways, so the treatment is activity modifications, once again, benign neglect, medications. Stretching is by far the mainstay. If you stretch this IT band and a bursa, your problem likely will go away. So it really just becomes adding a stretch to your day. Sometimes we send you to therapy. Sometimes we inject it with a cortisone shot, depending on how severe it is. But it does take a while to go away. It's not, hey, I got my injection, I'm good to go. And the goal of that injection is cure. If you inject arthritis, your arthritis is always going to be there. If you inject a bursitis, the goal is to get it to go away for good so you don't have to deal with it anymore. Now, it can come back in the future, but it's not something that is going to keep coming back or needing an injection. The injection usually is hopefully a one and done. If for some reason you try all of these things and nothing's working, that's when you start to think that, well, maybe this isn't a problem at the hip itself, maybe this is a problem in the spine. The injection itself, when you do it, actually goes straight into the bursa. And that steroid, so what's a steroid injection? A steroid injection is literally just taking a bunch of anti-inflammatories or taking a bunch of ibuprofen and stuffing at the problem, right? So if you take ibuprofen, where does it go? It goes in your whole body. And if you only have a problem at the hip, you take ibuprofen, it goes in your whole body, you're really diluting it down before it gets to the hip. So one way to deliver the anti-inflammatory medication directly to the hip is the steroid injection. And all it is an anti-inflammatory. It's not covering anything up. It's not masking the pain. The goal is truly to get rid of the inflammation in that bursa. And if you can get rid of the inflammation, you get rid of the pain. If you get rid of the pain, you don't have to come back to the doctor's office. So that's a good thing. So now we're going to spend the vast majority talking about hip arthritis. Once again, we talked about the anatomy. This is a nice looking hip. It's got really smooth white cartilage on it, sits in the socket. But unfortunately, when you have arthritis, that white cartilage on top deteriorates. That's what arthritis is. Basically, the cartilage cap is going away. If you think about your kitchen floor, if you've got a laminate kitchen floor, it's the lamination on top of the subfloor. Once you start wearing out that lamination, the subfloor is coming through, you have problems. And same is true here. Once you start to get that inflammation and it starts eroding the cartilage, here, now you have exposed bone in that area. Well, if that exposed bone rubs with that bone, that hurts, and hurts like the dickens, and causes groin pain. As far as arthritis goes, the end stage of arthritis is deterioration, but there's all kinds of different types of arthritis, more than 100 different types. The ones that we always hear about are osteoarthritis and rheumatoid arthritis, but there's other things called psoriatic arthritis and a bunch of other kinds like that affect the joints. Even though they're affecting some other system in the body, the joints deteriorate as well. So what are your symptoms of arthritis? Obviously, groin pain, first and foremost. We talked about stiffness, not being mobile, a limp or a waddling gait. What does that mean? So I get out of going to the mall with my wife by just sitting and watching people walk and commenting. But if you see somebody who walks kind of swinging to one side, just a waddle to one side, they probably have a bad hip on that side. If they waddle back and forth, they probably have a bad hip on both sides. So you start to see somebody with a bad hip waddle to the affected side or throw their weight over the top of that side because it's trying to protect the hip joint itself. This is what it looks like on x-ray. So if you look at this hip, you have a perfectly round ball. You have a space between the ball and the socket and a space here. If you look at that hip on this side, you no longer have a space. The ball and the socket basically marry themselves. They're tight against one each other. So once again, this cartilage is what you don't see on x-ray. There's really not a space here in real life. That's your cartilage. That's how thick the cartilage is. And remember, we showed that picture a little bit ago, that cartoon, where that cartilage wears out, and if it wears out, then you have the bone hitting bone. So a truly arthritis is the wearing away of the cartilage. It doesn't matter which joint it is, whatever joint it is. And so the other thing that happens with that is arthritis, by definition, you cause bone spurs to form. So this little triangle here is an extra bone spur. A little one down here as well. The bone spurs themselves are not the problem. Important. If you go in there and chisel those bone spurs off, guess what you still have? You still have bone rubbing on bone. So the bone spurs are just the body's way of trying to slow you down. So saying, hey, it hurts when I move. I'm going to create a bone spur. You're going to lose your flexibility because as you try and spin on that bone spur, it's going to hit and it's going to cause problems. You're going to lose your flexibility. But the true pain itself is bone on bone. So to have somebody just go in and chisel away bone spurs would not be an effective treatment whatsoever. So nobody's going to ever recommend that as a treatment modality. But you hear people all the time say he or she's got bone spurs. That's just meaning that the arthritis is far enough along or been there long enough that they've grown those spurs. So what can be done? Same type of thing, activity modifications. This is one where an assistive device does help. A cane, a walker, a walking stick like this gentleman has basically offloads that hip joint. So there's not as much pressure is going into that joint. Typically, we recommend you carry that cane on the opposite side. Sounds counterintuitive, but if you're going to carry a cane or a walking stick, it goes on the side that does not hurt typically. Weight loss helps. Over-the-counter medications, meaning the Aleve, the ibuprofens, and those types of things. This one's interesting. Physical therapy. The Academy of Orthopedic Surgery comes out with guidelines for most things, and they have what's called the Clinical Practice Guidelines for hip arthritis. And physical therapy at one point was thought to be one of the highest levels of evidence that it was actually effective. They downgraded that to moderate recently because they don't know if it actually works. So, meaning it has some evidence that it works, not really. It's a really interesting study, and I'm not poo-pooing therapy because I was a therapist before doing this, but they did a study where they did physical therapy. This is really cool, I think. They did physical therapy on patients using basically something called diathermy, where it looked like they were going to heat the patient up around the joint, and then we're going to use topical creams and things like that. What they used was placebo on these patients that actually didn't have anything on. The cream was literally just cream, nothing else. Those patients actually did better than the patients that were actually receiving therapy. So they're not sure what to do. So they downgraded this one to moderate evidence that it's effective. It clearly does help flexibility, but is it going to grow new cartilage? No, it can't grow cartilage. You can't grow any more cartilage than you had when you were a child. Steroid injections have an interesting place. We'll talk about those. And then obviously joint replacement. But as far as over-the-counter medications, things like this, anti-inflammatories, the important part of these medications is we take Tylenol, Aleve, Advil, those types of things for a headache. The headache goes away, you don't take them anymore. These aren't really effective to take a one and done. For these to treat the arthritis, you have to take them on a scheduled basis where they're actually going to build up in your system to keep the inflammation down. You would never take an antibiotic, and get 5 days worth and take it once and go, oh, the infection looks okay, I'm not going to finish up my antibiotic. No, you have to take the course. So those types of things typically a medication like that takes what they call 5 half-lives to build up in your system, but you need to take it on a regular basis for it to be effective long-term. And then obviously if you've got kidney problems or on blood thinners or any heart issues, obviously check with your heart doctor, your primary care provider, whoever that is first. I don't pretend to know that. Physical therapy, once again, stretching, exercises, and modalities, just different ways to try and regain the flexibility. But once again, the proof isn't necessarily there, but if it keeps you out of the operating room, it's probably a good thing. and then the injection. The steroid injection does the same thing once again as those ibuprofens or just the bursa injection. We do this under x-ray guidance because just to try and blindly throw that into the hip isn't very easy. So typically you lay on a table and myself or one of my colleagues will put the needle down into the joint and inject the steroid into the joint. It serves two really huge purposes. The first one is diagnosis. If we inject that hip with numbing medicine and the problem goes away, we can look very confidently at you and say, yes, the problem is your hip joint. It's not your spine, it's not the muscles around the hip, it's not a nerve. The problem is the hip joint itself. And I just did one of those today. We couldn't decipher if this lady's problems were coming from her hip joint, so we literally just filled her hip with numbing medicine. And she'll call back tomorrow to say, yeah, hey, the pain went away for the 6 hours that the numbing medicine was working, or didn't. And if it didn't, we know the problem was probably not her hip joint. It basically, you add the steroid on it, and the steroid calms the arthritis. It's like putting all the ibuprofen, once again, into the joint. The other good part about the steroid, there's life events that happen for all of us, right? Whether it be, taking the grandkids to Disney, a wedding that you want to go to, those types of things. And you can use that injection kind of as a temporizing measure to get you through a few months. It probably is not going to last 2 years or anything like that, but if you need to get through whatever life event that's coming up, that does serve a purpose, and we have to be cognizant to that. But you can't just keep doing injections because they will cause problems if you do them too narrow or too soon to each other. I did not mention, not by purpose, but I didn't mention, it's in the news all the time, platelet-rich plasma, stem cells, all of those things. That should be on this slide as well. But the literature right now doesn't support it consistently. So no insurance company really pays for that because there's no proof for or against. The studies are kind of what we call heterogeneous. They're just all over the board. Nobody can actually decide if it actually truly works or does not work. So just like the physical therapy sham study, there's studies for the stem cells and things that they're not conclusive. So you can try it. I know people that have tried it, not so much in the hip, but the knee and things like that. And out of the probably 20 people I know that have tried it, I think I've replaced about 18 of their joints. So take that for what it's worth. But it is really expensive. And once again, nobody's really certain if it works. So when do you consider joint replacement? When do you go this route? And in the aisles or in the pews of church here, there's a stem, and that's actually a hip replacement. Those are actually real ones that weren't in people, but those are real ones that go in people. And this cartoon shows one. It's basically, you're going to take off the ball here and put that stem that you see in the chairs inside the hip, and that becomes the new hip. So when do you do it? Basically, after all conservative things fail. You're not going to go to surgery right away. You're going to make sure everything else fails. And if they aren't providing relief, you're going to have a diminished quality of life. And then the one sentence I always say is, when you can't be yourself, then you're going to do something. I never tell anybody they need their hip replaced, their knee replaced, their shoulder done, or anything like that. You'll tell me. When you can't be you and do the things you want to do day to day, you're ornery, you can't sleep, you're not taking the dog out, you feel like you're dragging the family down because you're not walking the distance you want to walk, and it's kind of just pushing down on you. When you can't be yourself, that's when we talk about surgery, and not before that. You'll be certain you're ready for it when you come. I'll never tell you you need it. You'll come in and say you need it. So what's the benefits of hip replacement? First one, absolutely, reduce hip pain. That's the first goal. Second goal, third goal is number one. Enhance movement and mobility. Certainly, if it doesn't hurt, you're going to be more mobile. Common sense there. And if you can do that, your quality of life is going to improve. If you took all the surgeries in the history of the operating room, hip replacement surgery is the most effective and successful. So that includes heart surgeries, bowel surgeries, hernia surgeries, knee replacements. Pick your genre. As far as restoring a person to their functional activity and normal life and cost effectiveness and patient outcomes, hip replacement is on the top. So what is a hip replacement? Well, you have part of it in your hands there, but the other part of it is a shell. So what you see is that stem in the chairs, that stem goes down inside the thigh bone. You can put it inside the thigh bone because there are no nerve endings inside the thigh bone. We can't sit here and feel inside of our bones. So you can put that down inside. We also put a shell then in the pelvis or the socket, and then the ball goes on top. And between the ball and the socket is a piece of plastic. Typically it's a piece of plastic. And that has great 20 to 30 year data doing it this way. Often we don't cement it. We can put in cement to get it to stay. The vast majority of times we don't need to cement these things. If you look at the ones that you have there, they have a rough surface on them. Your bone actually thinks that's bone and grows into it in about a 6-week period. So after 6 weeks, if you want to get that thing out, you're going to need a chisel and a few hours of time to get that thing out of there. So it's typically made out of titanium. You can see a rough surface here, and then that stem has a rough surface on it as well. And then there's a piece of plastic between the ball and the socket. And we often use that. We don't use metal on metal. Was a hip replacement a few years, well, 15, 20 years ago. We don't do that anymore. It's not really on the market to do. The nice part about doing it this way, you have many options as far as what you can put in. If you look at those hip replacements that are laying around, they're all different sizes and they're all different shapes. And so it's not a one size fits everybody. You pick for that patient what the best option would be. If they have osteoporosis, if their canal is really big, if their canal is really small, how big is the patient? What are their needs? What are their age? Those types of things. And so all that plays into the type of prosthesis you put in. You don't just grab one off the shelf and use the same one for everybody. That wouldn't be right. Here's an x-ray of a hip replacement. So this is just the same thing that we saw in the previous cartoon, but you see the wedge down inside the bone, and then you see the cup, and then you can see the ball. What you can't see is the plastic. And there's a piece of plastic then between that ball and that socket. They are starting to have arthritis on this side. They're getting bone spurs there and there, but they still have a little joint space left. So whether or not you do anything with that side, we'll see. But that's what a radiograph looks like, an x-ray of a hip replacement. When you follow somebody along 10 and 20 years down the road, if they were wearing that hip out, you would see this ball start to go up because you'd be wearing the plastic out. So the way to check your hip in the future to see if it's wearing out is literally an x-ray. You don't need to open things up or anything like that. Every 10 years or so, we get an x-ray to make sure it's not wearing out. So, multiple ways to replace the hip. You came for the best part right now. This is the good stuff. All right, multiple ways to replace the hip. The traditional way, the way that's been taught for years, is called a posterior approach. It's the way I learned in the medical school, as well as in orthopedic training, as well as anterior lateral approaches. What we're going to talk about today is the direct anterior. The important thing is you're putting in the exact same prosthesis. You're putting in the exact same hip replacement. Doesn't matter how you get there. Doesn't matter how you get to Walmart. I can tell you how to get to Walmart or tell you how to get to Walmart. You both get to Walmart and you both buy the same stuff. So the end result is the same. It doesn't matter how you get there, but the end result of the hip replacement is the same thing. It's just how much collateral damage or what you do. So the traditional hip replacement is a posterior approach. The incision's on the side of a hip or towards the buttock. It's traditional, it's well taught. You can use it for almost anything as far as any surgeries around the hip area. So it's very extensive. It's comfortable for us surgeons because we learned it, we trained on it, and there's great long-term data that says how well it works. Nobody's going to argue that point. But there are disadvantages. You do have to cut a couple tendons to get in, or muscles off, but we call them tendons. Cut some tendons off the bone. You potentially have hip precautions, meaning they're told that if you have that surgery done that way, you're not supposed to bend more than 90 degrees at the waist, cross the legs, turn your foot out to the side, those types of things. And so with that, there's a higher rate of dislocation. And leg length equality is a little bit harder to manage. But it's very effective, works great. Those are just things that come up as a disadvantage. My current practice is I became interested in anterior hip. In anterior hip, the incision goes right here in the front, and we'll explain why that is in a second. But I've been in town for 19 years now, so that's crazy. So I started this 18 years ago. Nobody was really doing it around at that time. It wasn't taught in the residency programs. I called a gentleman in Texas who was doing it, and his name was Dr. Emerson. He had me come down. I got to go down and sit and do surgery with him for a week. It was great. You learn a lot by watching somebody else operate. He was an older gentleman, very pensive, thought about everything, and did a fantastic job. Taught me how to do it that day. So I prefer the first Biomet anterior hip in Wisconsin about greater than 15 years ago, and I haven't gone back since. So when I started, I was doing it the traditional way. I have not gone back to that way since. And for 10 years prior to COVID, I would go around the country teaching how to do anterior hips. And crazy enough, we had surgeons come here to Wisconsin Rapids, to Riverview, Aspirus, Riverview, or whatever we call it now, Riverview Hospital, as well as to our clinic to learn how to do anterior hips. They would come and they would scrub in, they would observe, and they would go back to their location and do hip replacement this way. And also, I would go around teaching, and teaching is really interesting. When you teach this, imagine the hotel room that somebody or the hotel large venue that somebody just had a wedding in. This is amazing to me when you think about it. So they just had a wedding on Saturday. You're now there on Thursday or Friday the next week, and you're teaching this. Well, the way you teach this is you go to a room and you do a didactic course like this, and then in that same room where all these people are going to eat dinner, you work on cadavers, learning how to do hip replacement. And the next day, they all eat dinner there. So it's, God bless the people that donate their body to science. I mean, it's fantastic. But yeah, literally, we'd go around and there'd be 10 to 15 bodies where people got to learn how to do hip replacements. And so I would go around and teach. And it's fantastic. You learn a lot doing that. And I learned a ton over those 10 years. So anyways, multiple ways to replace the hip. We're going to talk about the direct anterior way. So this is a anterior hip replacement where the incision goes. The patient's literally lying on their back and the incision goes here in the front. That's a small incision. That's about 4.5 centimeters. So it's at 2 inches, 2.5 inches of a hip replacement. So we put that piece of metal that you saw through that incision, which is pretty cool. So advantages. Well, first off, there's typically less pain leads to a faster recovery. No pillows needed. A lot of times in the old traditional way, you'd put a pillow between person's knees to keep their legs apart as the thing's healed. You don't need that. Outpatient surgery is true front and back now. That's the standard probably of care. COVID did teach us a lot of things. It taught us that we can do hip replacement and knee replacement surgery in an outpatient setting. Necessity is the mother of all invention, right? When nobody could stay in the hospital, we learned how to actually take care of this and do this in a safe, effective, cost-effective manner, a safe manner with actually better patient satisfaction and better outcomes in an outpatient setting than being an inpatient. So much so that Medicare, during that time of COVID, at one time you had to have all hip replacements, knee replacements had to be what we call inpatient, in a hospital. Well, they realized that was probably not the best use of your funds and your healthcare dollars and mine, and they came out and released that. They said it should be done in an outpatient setting now. And so they did a 180 on that back right at the time of COVID, which is good because it makes sense. With an anterior approach, there's no restrictions on movement. We're going to go why that is. We'll talk about that. Less dislocation risk and better leg length control. Those are benefits for the patient side of things. So that's good for you all. For me, this is better for me. I don't cut any muscles. I have excellent visibility. I can get great leg length determination, less dislocation, so I don't get called at night. It's the positions of the X-ray. We have an X-ray machine over the top of you as we're doing the operation, as we're putting things in, so we know exactly before we hit this with a hammer, we look and see on X-ray where it's going to go, so we can put that cup in exactly where we want to be. So you have direct feedback using X-ray. Obesity. Most people don't have a lot of fat right here in the front of their thighs. They just don't, compared to back here where we all got plenty of meat. So obesity is really not a factor at all. And obviously happier patients is a big thing. So here's kind of a cartoon version of how you do this. If you've ever had the experience of cleaning a deer or any animal for that matter, or even eating a steak, there's that little white silver lining between steak muscles that if you pull it apart, the muscles separate. When you do this hip replacement surgery from the front, you actually put your fingers between these two muscles, wiggle your fingers, and pull them apart. You pull them apart like you're looking through Venetian blinds or shades, and you can look through it and work in that hole. If you work in that hole, it'd make things a lot easier. So here's kind of the cartoon version. I'll talk through this, but person's laying flat on their back. This is their right hip. And what's going to happen is, it's cartoon. There's going to be no blood, obviously, but you need to look down, look down. So when you open the skin, there's a layer of fat. It's not very thick. It's only probably a ½ inch thick. You're going to take your fingers and literally put them between the muscles, and those muscles spread apart. And then we're going to cut, this is the ball or the thigh bone. The socket is here. So we basically cut the ball off, take a little sliver out, and then we can take the ball out pretty easily. Once the ball comes out, now we've got to actually make that socket round. So we take a coring reamer, if you will, and make it round. And then we pound in something that's a little bit bigger than the size of the hole we made. So that way it grips right away. At that point, we took the leg and put it into a kind of a figure 4 position. We need to clean out that canal, and so we do that. And then we put in the real stem, just like you saw in the chairs there. Then we put a ball on top of it, and once the ball goes on, we can put the hip back in its joint just by moving the leg back, and all is well. So that's essentially what an anterior hip is. It's the interesting part of a hip replacement is we actually do that surgery, whether you go posterior, anterior, you do the surgery at least twice, which is kind of crazy. So you do the surgery with trials, we call them trials, that we put in because we want to make sure, number 1, your legs are the same length, number 2, it's stable, number 3, it fits you. So we put all kind of practice pieces, if you will, in, take the leg through its motion, get x-rays, make sure everything lined up, and if everything lines up, that's when we buy all the things off the shelf. So in that room, literally there's shelves of the different types of prosthesis, the different sizes and shapes and lengths and those types of things. And at that point, then if it fits you and it's right for you and everything looks good, then we take everything back out and we put in the real thing. So it basically is you're doing it twice. So that's a kind of a cartoon version of it.
Sure.
Yeah.
How long does that take?
Surgery itself is less than an hour to do front to back. So when you go in the room, it takes about 20 minutes to get things set up. We typically do it under spinal, where we numb you from the waist down. You're also asleep because we don't want to be punched or kicked. So then after those 20 minutes, then the surgery starts. Incision to closure is typically much less than an hour, 45 minutes or so. It's like anything, the longer you're in there, the higher the blood loss, the higher the rate of infection. So it's not that you're speeding through, but you need to remain efficient and not, lollygagging, for lack of a better word. So then we take the trials out, we put in the real thing, confirm it on x-ray that everything looks okay, and then we'll close up the skin after that. So not everybody does direct anterior. There's plenty of research that says there's a steep learning curve, meaning that you should go to training. You shouldn't just try it because you read the book or anything like that, that you should go to training and practice on cadavers and any type of AI type of things that you can practice on. Whether you go front or back, obviously complications are real. Infection is kind of our dreaded one. The good news is typically at outpatient surgery centers, the infection rate is much less than large tertiary institutions. The risk of blood clots. Implant breakage, not very common anymore. Back in the early, basically 2000s or earlier, sometimes the implants would break. Malalignment, we've really corrected that by using x-ray in the room. We have x-ray so we can see it. If you can see it, the chance of walking out of the room and having something in the wrong position goes down exponentially, which is great. Premature wear. The plastics that you have in these hips now, we've probably all heard, 20 years ago, I'm too young to have a hip replaced, or too young, too active. Yes, there can be some of that, but the plastics were re-engineered right around 2004 to 2006. So those plastics that were lasting 15 years now are lasting 20, 25 years. We don't have that full track record on everything yet, but clearly it's not because I'm a better surgeon. The engineers did a great job of re-engineering the plastics at that time so they don't break down as much. So, 60 is not an uncommon age. 55 is not that uncommon of an age to replace a hip. Because if you're going to get 20, 25 years out of it, you can actually just change the plastic if somebody wears it out. It's akin to your brake pad, right? If your brake pads wear out, you just change the brake pad. You wait too long, you got to turn the rotor. If you do watch your hip and you watch it every 10 years, you could just change out the plastic piece. You don't have to change any of the metal, which is a huge benefit. No implant will last forever. We don't use, like I said, we don't use the same implant on everybody. If you're 90 years old, you probably don't need an implant that's going to get you 30 years. So you don't get that pimped out version. You get one that's going to get you 20 years or 15 years or whatever. But somebody who's 50, we want to put in something that's going to last a lot longer. And that's just a better of the metals and the plastics, or sometimes we'll use ceramic on those hips. Ceramic seems to is slated to last longer because it's a smoother substance than stainless steel. And obviously complications, anything you can imagine can happen between heart attack, stroke, pneumonia, all those things. So anybody that undergoes an operation like this with anesthesia has to see their regular doctor or primary care provider for pre-op clearance. That's a Medicare requirement as well, that you need what's called a history and physical before you can have an operation. So this slide I like to show all my colleagues that are in the cardiothoracic surgery. Obviously, it's a little bit old now, but follow me here. But red line is the number of heart bypasses going down year after year after year after year. This is why it's great to be in orthopedics. If you look at hips and knee surgeries, they're just continue to skyrocket. And then here's just another graph of it, and this is from our academy. By 2030, almost 500,000 knees and over 250 to 300,000 hips in the country. The reason being is people are demanding more out of their hip joint and they're staying active longer. Their heart, lungs are good. So why lose that quality of life? So more persons are going down that route of hip and knee replacement to try and maintain their active lifestyle. Here's a gentleman that this was the day of his operation. This was before we did our last remodel, but he had his hip replaced a couple hours earlier. Most of the time we force you to use a walker. He was heck bent on not using a walker that day, but that's his day of operation. So we get you up walking right away that day. So obviously, Wisconsin River Orthopaedics, we are here. We have a state-of-the-art orthopedic center and joint center. We are committed. We're small, but yet we're big enough where we are actually on the cutting edge. Question comes up is robots and all of those things. And robots have never been proven. This is crazy enough. They're great marketing tools. Everybody wants a robot and everybody wants a laser. It works for something. But they've never been proven long-term to alter the outcome of joint replacement surgery, whether that be knee or hip. So the guidelines at this point don't come out and say you should use a robot. We're up to date. We're innovative. You don't need to travel for great care. People, you always travel to go to the next supper club over, right? Because the food's always better, if you travel east for your supper club. But you can actually just stick in town here, and we can do it just as well. And we're definitely better outcomes versus national averages and our local competitors. That is clear. And we're committed to the community. We've been here for, do the math, since 1968, and we aren't going anywhere. The dollars that you invest in your health care with us come back to your community. We don't take them to Texas. We don't take them to California. We invest back in our community, and that's important. And then no referrals needed to come see us. You don't need to see your primary care doctor for anything orthopedic, whether it be shoulder, whether it be knee, whether it be hip. You can come and see us straight away. Back in the 80s and stuff like that, yes, you needed a referral, but that's not true anymore. That was just increasing the cost of care. So 2 shameless plugs. First off, we plan to do this, these public talks. We typically have done them at our building, but we think this is probably going to be a better venue. So we're going to do this probably 3 times a year. Shoulder pain, knee pain, back pain, those types of things as we go. But anyways, so for customer appreciation, we did this years ago when I first came to town, and we did it where we had a golf outing. But not everybody wants to do the golf outing. right? Some people don't want to golf, and I get that. So what we're going to do this year on May 19th, you'll start to see this. We're actually just going to do a brat burger fry. Everybody's welcome. And if you've had your hip or knee replaced or surgery by us, come out and say hello. Us surgeons will be milling around, hopefully not cooking for you. Somebody will do that. But it's at Tri-City, and you can call to register, and you'll start to see that. The other one we're doing is a ladies' night out. This will actually be at the clinic. I'm not in charge of it for obvious reasons, but it's going to be bone health in women, and please feel free to come to that as well. And last but not least, any questions? Whether it be hip, anything like that. So topic-wise, I'm not 100% sure. I think it might be shoulder pain for the next topic here. Just stay tuned to that. But we'll be, probably 3 and 4 times a year to do a public event for that. So, questions, concerns, or gripes?
So you showed the gentleman walking the same day.
Yeah.
Typically, how long does somebody have to be out of work?
Yeah, great question. So recovery time. People ask recovery time all the time, and I always tell people, and I'll get beat up here probably shortly, but farmers are 3 days, right? Farmers are going to go milk. They're going to go do what they need in 3 days, and they're going to go do that. You can't stop them, right? So the person, the self-business owner, is 3 days. Realistically, we tell you 2 weeks, you take it easy for 2 weeks. One of the biggest problems people have is that gentleman was going to do too much too soon, and he was going to have a big swollen leg. And he's going to call in a week and say how great he was doing at day 3, but he sucks right now because his leg is big and swollen. So we tell you, give it 2 weeks. At 2 weeks, when you come see me, I say, okay, now go be yourself. Start doing more and more activities. So if you've got to stand at Walmart, or if you've got to be in the mill and you're standing the entire time, probably 10 weeks is reasonable. If you've got a desk job where you can put your foot up to elevate it to get the swelling out and walk around when you can, 4 to 6 weeks is reasonable. So recovery is a very vague term, and it just depends on your job. But I'd say an office job, 4 to 6 weeks, you can put that in your head. And if you can control your environment, that's absolutely reasonable. But if you've got to stand at a cashier, for example, at the grocery store, you're not going to be very comfortable at 6 weeks standing for 8 hours. So maybe 10 weeks is more reasonable than that. Usually what happens, I'll see you at a 2-week appointment. We'll see you again at 6-week appointment. After 6 weeks, I typically don't see that patient again. At that point, they're given have a good life type of thing. X-rays look good. They're walking around. Most people will use a cane or a crutch for about 3 to 7 days, or a walker for that matter. Yeah.
The thing you didn't stress was, I think men have more mobility after they've had the type of surgery you do versus the other kind. As far as doing work, if you've got to lean on the floor or stand on the floor.
So the question is kind of, do men have more mobility after the surgery? Actually, if you look at men in surgery, we don't do very good, typically, for obvious reasons. You've heard of the man flu, but no, there's no literature that says men will have more mobility. And I don't know if anybody's ever researched it. I can't say anecdotally, but we start to have people tying their shoes, putting their own socks on, those types of things, usually about that second or 10 to 14 day mark. But yeah, I don't know that there's any literature that supports it. I would love if that was the case, but typically men don't do as well in surgery as females. And that's being sexist against my own.
After surgery,
yeah.
Men can do more things by having that direct therapy, surgery that you do versus the other kind.
Yeah. So you're correct. You don't have any limits with regard to mobility and motion. So you're right. So after 6, okay. I get what you're saying. So at 6 weeks, yes, or 2 weeks, whatever. I don't care if you ride a horse, cross your legs, whatever it is you want to do. You have no restrictions, whether that be pickleball or tennis or badminton or skiing and those types of things. Yes, that is correct. That they don't have any limitations after the anterior approach.
Right.
Yeah.
And that's really important, I think, to stress, because one of my friends went through the surgery with you, and that was one thing his mom kept telling me, was that there's more mobility after this type of surgery.
There's definitely more liberty to do what you want. I have a great picture of a woman who had her. So the Kennedy Center is in Oshkosh. It was a huge hip replacement center. He actually designed one of the prostheses that is out there, Dr. Kennedy. But he did a posterior approach, and all of his patients got a T-shirt when they were done. And the T-shirt has multiple stick diagrams and pictures of all the different positions they shouldn't put their hip in. And that was a posterior approach, and that was his reminder for those persons. The best part is that woman, I replaced her hip, and she showed up in her follow-up appointment. I should have put the picture on there, but it's just a giant circle with a red line through it, and it just says, Duellman did mine. And so it's cute. She did a nice job with it, but yeah, so you're right. So that mobility part, it's a big thing, because that's, if you go by the true guidelines, it says those mobility restrictions should be for 6 weeks to the rest of your life for the non-anterior approach. But for the anterior approach, we don't give those restrictions, because the chance of dislocation is actually only 0.6% for an anterior approach, which is a really, really low percentage. And those persons who have that are typically persons with a fused spine. So they have metal bars in their back or something like that. And then we do things differently for those persons. So. Any other questions? Yeah?
Do you do both hips at once?
Do you do both hips at once? You can. I've only done it probably 4 times. It's taxing on the surgeon and the patient. He's got to be really a perfect patient. No heart or lung problems. Willing to motivate it and have a good family structure, a good support structure at home. Have a damn good reason to do it. Because the complications might be, they're the same complications, but instead of having a small stroke, you'll have a major stroke. Instead of having a little heart attack, you have a major heart attack, if there's such thing as a little heart attack. But so the complications, the list is the same, but if one of those happens, it's exponentially worse. And that's where I shy away. Number one, it's just a tough recovery. To elevate both legs and sit there with both legs up is tough. Same goes true for both knee replacements. It's very difficult, and I've done a lot more than a half a dozen of those, but it's still tough. It's got to be the perfect patient, and the research says if they have hypertension, thyroid problems, diabetes, obesity, all those things, then you shouldn't do it, because you're playing with matches at that point. So we don't do that very often. Anything else? As far as there is no physical therapy after this anterior approach, or hip replacement for that matter. Typically, we're not cutting any muscles from an anterior approach, so your job is basically to go for a walk. We tell you just walk around the house. True story about walking around the house. Some people are extremely literal. This is a true story. In February, replaced a person's hip. I kid you not. He was spitting nails when he came and saw me at 2 weeks, and he was you just knew something he was a little bit ruffled around the edges. And finally, I just said, "Sir, you seem upset. What's wrong?" And he cussed a little bit, and he says, "Well, it's the middle of February." And I said, "I understand that, but what's the issue?" He says, "Do you have any damn idea how hard it is to walk around your house if you have to shovel the snow and you just had your hip replaced?" He was literally walking around the house instead of inside the house. So you learn how to verbalize things a little bit. Yeah, but he thought I meant walk around his house. So goodness no. So it's inside the house if you have to walk around. So any other questions at all?
What about going up and down the stairs?
Stairs are fine. Absolutely. So one of the most important things we do for this is education, right? The more you know going into the operation, the more you know about what you're going to get, the better off you are. So we do give you a book that's written by us at Wisconsin Orthopaedics, talks about how to do stairs with a cane or with a walker or with a railing and those types of things. But you can do stairs immediately after surgery. You probably just go one at a time instead of reciprocal, but you certainly will do stairs right away. Anything else?
This is off the subject a little bit.
Yeah.
This is for the hip.
Yeah.
What about the knee? This is kind of heavy.
Yeah, it is. Yep.
What about the knee?
The knee's actually heavier. So,
And the reason I asked that, I had a friend who had both knees replaced.
Yep.
He was a swimmer.
yeah.
And after the surgery, he went swimming and couldn't swim.
Well, I don't know about that. It's not like you're putting anchors on the guy. A knee replacement's about 16 ounces. I know that because I had a woman who was part of TOPS. I don't even know if TOPS exists anymore. But she was part of TOPS, and that's where you go in and you weigh yourself in every week, much like a Weight Watchers or things like that. And she called me because she gained 7 pounds, and she wanted me to write a letter that says that's why she gained 7 pounds, because of the prosthesis. So we went and put it on the male scale, and it's about 16 ounces. So I don't think that's going to cause sinking. Yeah, but yeah. So this part is actually made out of titanium, And then the ball itself is made out of a stainless steel, and that's where most of the weight comes, is the stainless steel ball.
So will that not respond to an x-ray then? Or when you go security?
Oh no, it'll trip security. We don't give cards anymore. Back years ago, they would talk about the cards that you would get and say you had your joint replaced. We don't do that anymore because after 9/11, if you were a terrorist, you would just make a card. Now when you go in the scanner and put your arms up, it scans you and it can see that you have a joint replacement. Or they put you in the separate line depending on which airport you're at.
I was told by someone that they went through security with a replacement and it didn't detect them. Is that?
It usually detects it. I have no idea about that TSA location. I don't know.
I thought maybe they're going to plastic.
No, it's definitely not plastic. All right. Anything else? Well, thank you everybody for coming. I sincerely appreciate it. Look to for another topic probably in about 3-4 months if we can get on the schedule here. And we'll kind of do that as a series. And then look for the girls' night out that's coming up right around Mother's Day, actually. And then we have that thank you event at Tri-City Golf Course coming up as well. So thanks for coming, and I look forward to seeing you next time. Thanks.